Respected office bearers of Maharashtra State Chapter ISA, Dr. Sare Sir, Dr. Avinash, Dr. Anita, Dr. Samir, Dr. Hemant, dear Dr. Vijaya Madam and Dr. Jason, who are the moderators for today's session. And I must say, I'm very thankful to all the faculties, the young dynamic faculties, Dr. Gauri, Dr. Sonali, Dr. Vrishali, and Dr. Sachin, who accepted our invitation and have joined for today's webinar. You all know that Airway is such a topic which is very close to our heart. And we always discuss so many things about Airway, and there are so many guidelines. I just saw one slide of Dr. Vrishali. There are so many guidelines for the Airways that has been published till now. But still, we are always worried whenever we get a difficult airway. So let us discuss today regarding two important issues. The use of video laryngoscope in a difficult airway situation. And what about Buji? Is it useful or still not? Or should we abandon the use of Buji in difficult intubation, especially Malampatti grade 3 and grade 4? So without wasting much time, we will continue with the further program. I request Dr. Anita Nethe, Vice President, Maharashtra State Chapter ISA, to continue the further program.
Thank you, Manisha Madam. And I would like to welcome Dr. Vijaya Patil Madam. Our please display Madam's CV. Dr. Vijaya Patil Madam is a professor and head of department of Tata. Hello, am I audible? I think my connection is.
Yes, you are audible, yeah. Anita. Just continue.
Yes. So Dr. Vijaya Patil Madam is the professor and head of clinical anesthesia department of anesthesia, critical care and pain at Tata Memorial Hospital. And actually she needs no introduction. She's so humble that she has just given this much small slide for as a CV. But we know that Madam has very many publications to her credit, and she has given many lectures, given many workshops, and she has many students who are practicing in Maharashtra. So with this very short introduction, I welcome you, Vijaya Patil Madam. Avinash? Please unmute yourself, Avinash.
Yeah. Sir, please.
Yes.
Sir, please unmute.
Yeah. Hello, good evening to all. So it is my pride privilege to introduce my friend, Dr. Jason Doctor. I know since long time he had conducted one workshop of Airway in our own hospital, quite some time with the team of Dr. Sheila, Jiggy, and Vijaya and Gedu. So since then I know him, how much they are working in the airway management workshops. So he's currently holding the position of professor and consultant anesthesiologist at Tata Memorial Hospital, Mumbai, which is one of the prestigious institute in India. To his credit, he is a postgraduate teacher, and many students have come out under his guidance from Tata Memorial Hospital under anesthesia. Moreover, he is one of the academicians, and he is one of the committee members to set the guidelines of All India Difficult Airway Society, Association of Society, wherein we are following those guidelines, and he is one of the member, and he was there in 2016. With his credit as an academician, he was an editorial board from 2017 to 2021 of Indian Journal of Anesthesia. He is one of the peer reviewer of Indian Journal of Anesthesia, Journal of Anesthesiology and Clinical Pharmacology, and Airway and International Journal of Molecular Science. He has got numerous publications, more than 39 publications, national and international, and he has wrote 10 chapters in the book. He is one of the faculty for numerous national conferences, which we have witnessed most of the national conferences. And now he is holding the National West Zone member position or 21 to 23 of All India Difficult Airway Association of India. Thank you so much, Jason, to come for this Maharashtra state chapters. And the Tata team is well known for all these things. We'll hope this today's session is going to be a great feast for the difficult airway, which is one of the most common problem every day people are facing. Thank you so much.
Thank you, Saleh sir. Good evening, all. Welcome to today's Maharashtra State Chapter ISA interactive session number 8. Pros and cons session, Airway. Today's first debate topic is VLS for difficult airway, solution or just strategy. First, I introduce Dr. Gauri Gangakadkar, madam. She is a DA and DNB. She has done his fellowship in neuroanesthesiology. She is affiliated to the Tata Memorial Hospital, Mumbai. She is assistant professor, Department of Anesthesiology and Critical Care and Pain. She has 35 publications in index journals in his credit. She got multiple awards for presentation, including first prize at SOAP Conference 2018 and BNA 2019 GSA paper presentation in 2019 and winner of ISA and ACC quiz 2018. Her areas of interest is neuroanesthesia, oncoanesthesia, difficult airway, and patient safety. Welcome, madam. Our second debate, Dr. Rishali, madam. Varsha, please. Rishali Ankalwar, madam, is associate professor in Department of Anesthesiology, GMCH, Nagpur. She is MD, FI, PM, Delhi and Calcutta. She had teaching experience of 17 years. She is recognized PG guide. She had 20 publications, of that 16 are original article and 4 case reports. Her recent publication, Comparative Evaluation of Intubation Performance of No Voice Resident with Air Track and Macintosh Laryngoscope. Her special interest is in pain medicine, pediatric anesthesia, and airway management. She is reviewer of peer-reviewed and indexed anesthesia journal. She participated in several anesthesia clinical trials. She was invited as a faculty at many anesthesia conferences, CMEs, and workshops. Welcome, Rishali, madam. I request Gauri, madam, to start with the debate.
Dr. Gauri, unmute yourself.
Yes, ma'am. 1 second. I'll just share the slides.
Yeah.
Very good evening to all of you. I'm Dr. Gauri Gangakadkar, like I was introduced. Thank you so much for the very kind introduction and the invitation to speak for such an august assembly. I'm going to be speaking on video laryngoscopy. Is this better, sir?
Yeah.
Yeah, thank you, sir.
Yeah, please continue.
I'm going to be speaking on video laryngoscopy, which I believe is a definitive solution for a difficult airway. When you ask about difficult airway or when you talk about video laryngoscopes in the difficult airway, our debate is not about whether or not they have a place in the management of difficult airway, but whether or not they form a solution for difficult airway management. So where do they hold this place? When you think about a difficult airway, the American Society of Anesthesiologists classifies a difficult airway on 3 parts. You could either face difficulty in mask ventilation, or laryngoscopy, or intubation. The video laryngoscopes come here. Video laryngoscopes are of use when you're facing a difficult laryngoscopy. So much so that these video laryngoscopes, since their introduction in 2001, have found a place without replacement in all of the difficult airway guidelines. In fact, the 2022 difficult airway guidelines from ASA, or whether they're the Canadian guidelines, the Difficult Airway Society guidelines, or even our own IDA guidelines, mention video laryngoscopes as a choice of equipment in difficult airway, whether as a first choice or as a rescue. When you're using a difficult airway, the next question that arises is how much do they really help during a difficult laryngoscopy? To help us understand this, we need to look at the Cochrane review, which was presented by Tim Cook et al., where they studied randomized control trials up to 2015, which compared video laryngoscopy versus direct laryngoscopy in adult patients requiring tracheal intubation. They were able to elicit 64 randomized control trials with data from 7,000 patients from the Medline, Scopus, and Cochrane. They found that the use of video laryngoscopy reduced laryngeal or airway trauma, reduced hoarseness, increased the ease of laryngeal views. That is, in most of the studies, they found that the intubation difficulty scale was used. So they found the better scores were seen when video laryngoscopes were used. Reduced intubation difficulty, that is, reduced difficulty in actually passing the tube through the glottis, was also seen. And additionally, failed intubations were seen to be reduced. Now, all is well until your patient has a slightly reduced mouth opening. What happens when your patient looks like this? Here, you face multitudes of problems. The problem is not just an anatomically difficult airway. Here, you see that the patient still has an oxygen requirement. So this is a physiologically difficult airway as well. What happens then? Can we still use video laryngoscopes? And the answer is very much yes. Video laryngoscopes are now being used very commonly for awake video laryngoscopy. In fact, of course, this is done after topicalizing the airway, like you would perform a fiber optic intubation. Here, we find ourselves with two alternatives now. You could use the video laryngoscope by itself, or you could use it with a fiber optic bronchoscope, like is shown in the second picture, where they've used a glide scope in conjunction with a oral fiber optic intubation, or even a nasal one for that matter, to get the tongue out of the way. In fact, the awake video laryngoscopy now finds itself as a part of the latest DAS guidelines, the ASA guidelines, and even the Canadian guidelines. When Rosenstock et al. Have compared the time required for intubation between awake video laryngoscopic intubations, they found that the time to tracheal intubation was 80 seconds with fiber optic, and it was 62 seconds with a video laryngoscope. So the time is comparable whether you use a video laryngoscope or not, or you use an awake fiber optic intubation. They found that the operators were slightly more comfortable when they were using video laryngoscopes, and the patients did not face any additional difficulties when video laryngoscopes were used as compared to fiber optic intubation. Unlike our direct laryngoscopes, video laryngoscopes are available in a plethora of varieties. Not only are they different to look at, their technologies are so you would have channeled video laryngoscopes or non-channeled video laryngoscope. You could have a chip at the tip of the video laryngoscope which helps vision, or you could have fiber optic cables running through them which aid vision. We could also have prisms which aid vision. Multiple studies have been conducted with multiple video laryngoscopes that prove their ease of use in difficult airway situations. They've been conducted on mannequins where a difficult airway has been simulated by use of, say, cervical collars or increasing the size of the tongue, and even in patients in difficult groups, particularly such as those who are obese or in trauma patients with cervical injuries. So how do we know which one do we use? There is a study published in the British Journal of Anesthesia, which evaluated 6 video laryngoscopes in 720 patients with a simulated difficult airway. This was a multi-center randomized controlled trial where these patients had limited mouth opening, and then additionally cervical collars were put on to limit the neck extension. They used 2 kinds of video laryngoscopes, unchanneled and channeled. As you can see in the results, the first attempt success for video laryngoscopes was excellent. Failure to intubation was not seen at all due to any technical issues. The study concluded that McGrath and CMAC-B blades were not only associated with the highest success rate, that is close to 98% while intubating, and also caused the lowest amount of tissue trauma. So what happens when you change your video laryngoscope? Or for instance, what if your institute buys a new video laryngoscope? Or sometimes you often hear people saying that the video laryngoscope has a steep learning curve. To address this learning curve issue, there is a dictum that we use: the more I practice, the luckier I get. Essentially, your technical skills improve with practice. Various studies have been conducted which suggest that 6 to 20 intubations done even on mannequins appear to be sufficient to make the learner comfortable with a video laryngoscope, particularly if you're already trained in intubation. When this was assessed further in an emergency airway department where you could get a mix of difficult airway patients and routine airway patients, they found that on dividing patients into normal airway groups and difficult airway groups, the time to intubation was shortened in both normal and difficult airways when the students were given a video laryngoscope to use. The learning curve was also very much improved when video laryngoscopes used, where the time to event, when you're comparing time to event analysis, one was found highly significant. As you can see on the graph on the right, the red line marks those operators who used a video laryngoscope, while the line on the blue marks those who used the regular traditional laryngoscope. The total learning time in seconds that was required by the group that used video laryngoscope was significantly shorter. What this translates into is that acquiring a new video laryngoscope and acquiring the skills to use a new video laryngoscope with safety and with precision is not difficult at all. When we focus on our recent pandemic, we realize that these video laryngoscopes were complete lifesavers. They allowed the intubator to be further away from the patient and reduce the risk of exposure to airway secretions and contamination. Our airway management during COVID was already complicated with the use of aerosol boxes. The patient was already further away. Our arm movements were limited. So a routine airway tended to become more difficult. A recent study found that the ease of intubation was definitely better when a video laryngoscope was used as compared to a traditional direct laryngoscope. 68.6% of the operators found that they were able to achieve a POGO of 1, that is percentage of glottic opening 100%, with the use of video laryngoscope. None of the patients in the video laryngoscope group required more than 1 attempt as compared to direct laryngoscopy. Ours is a tertiary training institute where we received residents during that year too. We found that on giving them these video laryngoscopes to handle even in easy airways, they were able to intubate. But using a direct laryngoscope in conjunction with an aerosol box made the task extremely difficult. So given this, what is the current opinion among anesthesiologists in India with regards to the use of video laryngoscopes for difficult airway? A recent survey was conducted on 666 members of the ISA. Here, only 42% of the members suggested that they had access to video laryngoscopes. Most of these participants were from corporate hospitals. In 20% of these, the participants suggested that the access was restricted to consultants alone. Unfortunately, this doesn't paint a very promising scenario for video laryngoscope, but the results were truly heartening. Because we found that when an unanticipated difficult airway did come up, video laryngoscope was still the first preference for 49% of the respondents. If this doesn't go to show us that once you get used to a video laryngoscope and you find how easy it makes your life, you're never going back. To conclude, video laryngoscopes are definitely the future of laryngoscopy. As airway practices evolve to increase patient safety, video laryngoscopes become the obvious choice. The use of video laryngoscopes in patients with difficult airway offers a one-stop solution for a vast majority of patients, either as a first choice or as rescue therapy. Like I said, we work in a tertiary care onco institute. We have a lot of head neck patients, and I can personally vouch, as can Jason and Vijay madam, that these video laryngoscopes have been life-saving options on more than one occasion. I thank the organizers again and hand over to Vrishali madam for her presentation. Thank you.
Excellent presentation, Gauri ma'am. It was really excellent. And I'm sure in presence of Dr. Vijay and Dr. Jason of your department, you gave evidence-based solution that definitely VLS is a solution. So, but now we have to listen to Vrishali, and she's going to say about whether it is not a solution. She's going to prove us again evidence-based that it is a strategy. Vrishali madam, please share your screen.
My slides are visible to you, ma'am?
Yes, yes. Yeah.
It's not going.
You can see your slides, yeah. Start your presentation, Vrishali ma'am.
Good evening, everyone. Without wasting time, we'll go to the topic directly. My topic is VLS for a difficult airway. It is just a strategy, not a solution. Before we proceed ahead, let's see the definition of difficult airway. It is a clinical situation in which conventionally trained anesthesiologist experiences difficulty with the face mask ventilation of the upper airway or difficulty with the tracheal intubation or both. So this situation is not less than a sinking Titanic or a tornado storm in a city. We all agree to this. And to deal with such a sinking Titanic situation, there are n number of the guidelines formed by our own people, anesthesiologists and the society, like DAS guidelines, CAFG, ASA practice guidelines, and IDA guidelines from our own home to suit our own situation. Okay, and the armamentarium is also ready to deal with the difficult airway, and it is also reflecting our change of lifestyle. Like earlier, we used to have a small suitcase, we used to pick up a required cloth, and that's all. But now our situation regarding our cloth is like this. Similar is reflected in an armamentarium of a difficult airway. It was like this. All old anesthesiologists will agree to this. Only few blades of the Macintosh, Miller, McGill, and Airways are nasal airways. But now we have all the HIFA gadgets, and the highest one is this difficult airway card. This is the most sophisticated version we can have right now. Okay, and our guidelines, IDA guidelines, have also suggested a proper plan how to keep these equipments in our armamentarium, and has given us a guidelines to arrange in a drawer to avoid the chaos or chaos. Like they have included everything from starting from the laryngoscopes, video laryngoscopes, SAD, cricothyroidotomy, everything. It indicates that the video laryngoscope is not the solution. And you can see also that in the list of the desired equipments in a difficult airway card, in mandatory list, it's a working laryngoscope with the Macintosh blades. And in desirable, if you can see, it's a video laryngoscope, is desired one, not a mandatory one. Am I audible?
Yes.
Yes, madam. Yes. Please
the
continue.
desirable video laryngoscope is in a list of a desirable gadgets, not the mandatory. However, the Macintosh is in the mandatory list. If we are not, if the video laryngoscope is the final solution of all difficult airway, then our trolley should look like this. No requirement of any other gadgets. No, neither SAD, neither cricothyroidotomy, neither any mask ventilation, nothing. We can directly pick up the video laryngoscope, intubate, and go ahead in any kind of a difficult intubation. But it's not so, because the video laryngoscope is not the ultimate solution of all difficult airway. To understand this, why the video laryngoscope cannot be declared as a solution, we have to peep into the history and literature. Like first laryngoscope, that is glide slope, it was introduced 20 years back. It was an extension of indirect laryngoscopy. Of course, it was a revolutionary invention for the management of a difficult airway, and everyone agrees that the introduction of video laryngoscope has changed the whole scenario of difficult airway. Even I also agree. That is why it should be a part of a strategy, but it can't be declared as a solution. Why? And you will also see the market is, after the introduction of glide scope, market also flooded with variety of video laryngoscopes. Some were having screens, some were handheld, some were channeled, some were guided. There is a big classification of video laryngoscopes, creating more and more confusion. But VLS has definite advantages over the conventional Macintosh, like direct visualization of glottic opening, improved CL grade, high first pass attempt rate, higher successful intubation rate, like 88% to 100%. But you can see that Macintosh is also having 100% successful rate. But with the use of VLS, they have scored the less airway trauma and the participation of other team members if you are using a video laryngoscope screen. Like other people can also see the screen and guide the operator, aisa dal, vaisa dal, and they can get ready for the another next step also. That is biggest advantage of VLS. I do agree. So it should be a part of a strategy, but can't be a solution. After the flooding of too many laryngoscopes in a market, many studies were also conducted, like comparing Macintosh with the glide scope, or AirTrack with the King Vision, or glide scope with the AirTrack optical in a number of the clinical situations, like in cervical spine, in emergency department, in ICU department, etc., etc. But the latest one, which is published in a anesthesia journal in 2021, which is meta-analysis of a video laryngoscope versus direct Macintosh laryngoscope in a tracheal intubation adults, has confirmed that video laryngoscope and Macintosh direct laryngoscope may be considered clinically equivalent for the time taken for tracheal intubation. But still, they say the current available evidence is not sufficient to ensure significant superiority of one device to the other, and they were not ready to suggest any intubating gadgets over the others. Just a minute. So out of all this confusion and too many gadgets, video laryngoscopes available in the market, a beautiful comment came in the on this article, that mirror, mirror on the wall, which is the best laryngoscope, all of them. It was very difficult. Now, which is the video laryngoscope which is most suitable to your situation? So the confusion is still going on. And if you consider the cost, which is the one of the biggest limitation of use of video laryngoscope, let's see CMAC, which has performed the best and has topped the list of video laryngoscope in performance. It cost around 20 lakh, glide scope around 15 lakh. If you go for a handheld VLS for your personal use, then reusable like King Vision, AirTrack, they come around 2 lakh. If you want to use disposable VLS like AirTrack, they come in 5,000 only, but it is really disposable. You have to dispose it off within 2 or 3 uses. So what to do? What to pass the message? If the society or experts are saying that it is a solution for all difficult airway situations, then we have to start funding the new anesthetists, or we have to start a bank loan system for them. And if you want to CMAC for your personal use, then you have to start for a crowdfunding. Like we have to start a bank loan in a name of starter loan, like they give it to the engineers for buying a laptop and all. We have to give them funds for buying a video laryngoscope if we consider this as a solution. Let's move on further. What are the hurdles? Then learning curve is the biggest hurdle, because there are such a big array of video laryngoscope. As my opponent friend said, every gadget has a different learning curve, and you have to get trained in that video laryngoscope. If you change your institute, then your video laryngoscope is changed, and so you have to again acquire the new skill with that new laryngoscope, new video laryngoscope. That is another hurdle. There is a wonderful article by Gupta et al. Published in 2021, Evolution of Video Laryngoscope in a Pediatric Population. If we go through that laryngoscope, they have mentioned thoroughly each laryngoscope and its technique of insertion. Oh my God, it's such a big task to learn all the laryngoscopes, very difficult. So do you really want to get deprived of a simple skill of picking up the direct laryngoscope and intubating the patient? Or do you want to get expert of this all big hi-fi gadgets in the name of a technology or a modernization? No, not possible. An opponent friend may say, oh, about the VLS, to defend VLS, they may say that, oh, these are the personal, logistic or financial issues. Or they may also say, oh, this is an ego problem of an old anesthesiologist. Just because they have trained themselves in a direct laryngoscopy, they don't want to leave that and accept a new thing in name of modernization. But no, it's not again an ego problem. We always like to go ahead, and we always are in a favor of adopting a new technology, but there are issues with VLS. So let's see what the guidelines says, which we follow for managing any difficult airway situation. We all agree that guidelines to manage difficult airway are a structured stepwise approach to manage unanticipated difficult intubation. They are developed or based on the available evidences. And wherever the robust evidences was lacking, recommendations were arrived by the conscious opinion of airway experts, incorporating the responses of a questionnaire of the members. And it's a diligent work and it's a task force level work. We all agree to this. Let's say what these guidelines say. Whether they consider laryngoscope as just a strategy or a solution. If you see the DAS guidelines, their algorithm, they have just said first step laryngoscopy. They have not mentioned any device. Okay. Let's see the recent one, 2022. They have included all non-invasive devices for the difficult intubation, like rigid laryngoscope, rigid bronchoscope, fiber optic bronchoscope, and video laryngoscope also. But in the last, they said the literature is still insufficient to evaluate which devices are most effective when attempted first after failed. Again, controversy goes on. Now, they have also briefly thoroughly evaluated video laryngoscopes. Like they have compared video laryngoscope with the Macintosh, with the FOB, with channeled against non-channel, angulated versus non-angulated, and I'm damn sure video laryngoscopes has performed very well in terms of high success rate, low time for intubation, and high first pass success rate. But again, they did not say anything which intubation gadget you should pick up. And the evidences in favor of video laryngoscopes are quite good, like category A1B, category A1E. The level of evidence is very good when we discuss the video laryngoscope performance for difficult intubation. But what happened when they formed the guideline? When they formed the algorithm, they simply said that difficult airway algorithm for adult patients, it is the airway manager's choice of airway strategy and techniques, and it should be based on their previous experiences, available resources, including the equipment. Okay, kindly note this. And in awake intubation techniques, they have also included flexible bronchoscope, VLS, direct laryngoscope, also included combined techniques, and not last but not least, they have also included retrograde wire aided intubation. Why? Because they know that only one gadget cannot form a solution for a difficult airway situation. What Canadian Air Force focus guidelines did, they also studied a video laryngoscope with direct laryngoscope in 2021 publication, and they recommended that video laryngoscope can be used for a difficult intubation. But again, in the algorithm, when the unsuccessful first attempt at tracheal tube, they have not mentioned video laryngoscope anywhere. They have simply said, you change the operator, change the device. But they were aware that video laryngoscope is a very useful gadget. So in an emergency situation, like eminently hypoxic situation, they have given a place to the hyperangulated blade of a VL along with the SGA and FMV for a single attempt. So here again, it proves that it can be a part of a strategy, because video laryngoscopy are very useful, but it can't be a solution. Our own home guidelines, which are structured according to our need. In the step 1, only video laryngoscope has failed along with the direct laryngoscope. So do you think, because they think that it is not a solution, but they have taken in a strategy. So in case of anticipated difficult intubation like this, usually we prefer awake intubation, and usually it is with the fiber optic bronchoscope. So let's see benefits of video laryngoscope and FOB for the awake tracheal intubation. Literature says that both gadgets require similar depth of anesthesia and a preparation of airway. Does anyone agree with me? What about the depth of sedation? If you prepare an airway for a fiber optic bronchoscope and then you suddenly put a video laryngoscope inside, patient is going to throw us. I know. So definitely the depth of anesthesia and depth of sedation is required, is more with the video laryngoscope than with the fiber optic laryngoscope. Yes, but video laryngoscope still has a definite advantages, like it gives a broad view of anatomy. We can see the tube passing between the cords. We can avoid the pink out situation, and we can use all sizes of stellated tracheal tubes. But VL may not be an option with some anatomic and fixed neck flexion masses. Here the FOB gives a definite advantage over the video laryngoscope. It can be used for a navigation through all the planes, like obstructing airway masses. We can see the advancement of the airway. We can put the tube along the nasal route, which is the biggest advantage of FOB or the video laryngoscope. We can confirm the successful tracheal intubation, and we can see where the tracheal level of injury and where the level of fistula, so that we can pass our tube beyond that level. In pediatric population, as VLS, all types of video laryngoscopes are available with all types of blades. And of course, again, CMAC found to be superior over the other VLS. But the more airway maneuvers and the use of stillates was more in pediatric population when video laryngoscope was used. What are the challenges for VLS in pediatric population? Airway is different and difficult as we compared with the adult. Time for intubation is less. Hypoxia is more rapid and more devastating. Airway trauma is very less tolerated. Hence, you cannot go and start doing scopy with each and every type of video laryngoscope in pediatric patients. And you need to have a different range of blade sizes required. In many of the neonatal intubation guidelines in ICU, they have kept it as a plan A plus, not in a plan A. Video laryngoscopes in a neonatal intubation are in a plan A plus. And the most biggest nightmare of our medical life is COVID era. So to reduce the aerosol contamination, initially video laryngoscope was promoted and taught to everyone. And even many of them bought the video laryngoscopes also. CMAC was again found to be useful, but the availability was issue. There were so many barriers while intubating the patient, like screen, goggle, and fogging. And the worst part, as the pandemic progressed and intensified, doctors from all fraternity demanded to intubate. They simply said, "Madam, ये क्या है? ये हमको नहीं पता. We know only direct laryngoscope." And even after giving the video laryngoscope, they throw that and they picked up direct laryngoscope and start intubating the patients. We have done many intubations with direct laryngoscope, and our old friend, 100 years old friend, has really done well and performed well in COVID era while intubating our COVID positive ICU patients. So at the end, while concluding, like हर बीमारी का एक ही मर्ज नहीं हो सकता है, वैसे ही हर डिफिकल्ट इंटुबेशन सिचुएशन के लिए वीडियो लैरिंगोस्कोप कैन नॉट बी अ सॉल्यूशन. ओनली इट कैन बी अ one of the strategy for managing difficult airway, but it has limitations also. So VLS should be a strategy, but not a solution for management of a difficult airway. Thank you very much to all the dignitaries. Thank you very much.
Excellent presentation, Dr. Vishali. And when I was listening to Dr. Gauri, when I was listening to Dr. Gauri, yes, I thought it is a solution. But when I listened to you, now I started thinking that it is a strategy. So let's listen to Gauri again, what she wants to say. Let's listen to Gauri again, what she wants to say.
Congratulations, ma'am, on an excellent presentation, Vishali, madam. Ma'am, I'd like to start my counter with the fact that the video laryngoscopes are not here to replace the nasal fiber optic intubation. They are not here for that. What we are not even trying, when I say when I'm countering your argument, the idea is not to get rid of our direct laryngoscopy skills at all. We need our direct laryngoscopy skills. The idea behind introducing a video laryngoscope as a one-stop solution is that the size, like you said, exactly like you said, the size of our difficult airway card will reduce in the future. The number of times that I have to move from plan A to B to C to D will reduce if my plan A or my plan B, my plan A includes a video laryngoscope. With respect to the guidelines, madam, I'd like to point out that all of our guidelines are based on infrastructural availability. And with regards to that, they must be inclusive. If we look at the availability of video laryngoscopes in our country, in the small sample set that was used in the survey that I spoke about before, less than 50% of the institutes had even had access to the video laryngoscope. So our national societies cannot recommend the use of video laryngoscopes for all. However, if the promise is that the patient is safe and we are able to intubate faster, I'm sure that we can look at a way to consider the cost of a video laryngoscope as an investment in the institute and the patient's safety rather than a limitation. While the cost does prove to be of a disadvantage, where the CMAC does indeed cost 20 lakhs, none of us are strangers to the borescope video laryngoscopes, which were created as a part of the pandemic and have found a place even in the Lancet as far as publications go. A simple borescope, which is used by the mechanics for cleaning small parts or repairing small parts in the car, can cost as little as 100 rupees on Amazon. And all people have done is tape it to their direct laryngoscopes and have gotten and then connected to their smartphones to create their very own, very affordable video laryngoscopes. Like Madam pointed out, there are a vast array of video laryngoscopes in the market. Rather than look at that as a difficulty or a source of confusion, I think it is a matter of availability of choice. When my patient's mouth opening is a lot more restricted than I would find, the channeled video laryngoscopes offer a solution in the form that I do not require additional place to manipulate my tube into going into the glottis, and that is done. With regards to Madam's point that every time a new video laryngoscope is bought, she would have to retrain, or anyone would have to retrain. It is a simple question of practicing 5 or 6 times on a mannequin without even reaching the patient, and we're good. With how much we center ourselves on keeping our patients and our airways safe, this offers a simple solution. I'd also like to point out that there was a Cochrane review that was cited by Madam, which spoke about the non-inferiority of video laryngoscopes over regular laryngoscopes. Madam, that review was conducted in a regular airway. In regular airways, in an MPC1 patient, in a Cormac-Lehan grade 1 patient, whether you use a direct laryngoscope or you use a video laryngoscope, our intubation times, our intubation success rates are rarely going to matter. The change will come when you actually have a difficult airway in your hands. And that is where the success matters. And video laryngoscopes, which are not disposable, tend to prove as an investment to our institutes. So once you have mastered one particular equipment, you will be able to handle all of them. We do need to teach our residents to do a proper direct laryngoscopy. There is still no getting around that. In fact, a recent article in the Indian Journal of Anesthesia even debated whether or not it was time to outmode direct laryngoscopy. We are clearly not there yet. But if there is an option that I do one laryngoscopy and I don't need a plan B, C, D, I think I'd take it. Thank you, Madam.
Hello, am I audible?
Yes, please stop sharing your screen, Vishali, so that we can see you clearly.
Okay. Okay, thank you. Thank you, madam. I do agree with Gauri madam that video laryngoscope are excellent airway equipments and they really reduce the incidence of difficult airway. But here one article I read from a very well-reputed journal that if you reduce the difficult intubation incidence, then how our student and future generation will get exposed to that hurricane type situation, how they will get trained in managing difficult intubation situation. My question is valid or not? So it doesn't mean that we should avoid difficult intubation, but still that is one part. When we land up in difficult intubation, our students, we also learn so many things from that situation. When we successfully intubate the patient, then we all are sitting, and then we review that what we done, we use this, we use that. And thanks to all these guidelines, the chaos is really reduced because they are done so, well, they have algorithm is given so nicely, the chaos is really reduced. And then institution, yes, in institution we do also have CMAC. We regularly use, even I am also a fan of a CMAC, but my senior teachers say, या मुलांचं कसं होणार, हे नुसते CMAC ने इंटुबेट करतात, यांना बाहेर जाऊन हा CMAC मिळणार का? Then I realized, yes, she's senior as senior. And then I removed that CMAC and kept in our room. And you intubate with the direct laryngoscope. If you find any difficulty, you can quickly pull that video laryngoscope, and till that you should know how to do the face mask ventilation and oxygenation. Gauri madam, I'm right or wrong?
Madam, like I said, there is no debate. You need to be able to mask ventilate. You need to be able to use the direct laryngoscope. But I cannot debate the fact. Honestly, if the question is if the children do not develop those skills, it's fine. If they kill one less patient through their career, I think we've won it all. The patient cannot be put at risk because we want them to train on a difficult airway. They can still follow the guidelines. We can still keep our plan B, C, D intact, but we can learn with simulators, madam. Mannequin वर practice करू शकतील ते. काही problem नाही
I do agree with you that video laryngoscope is a wonderful gadget.
There is no issue.
I do agree with you that video laryngoscope is a wonderful gadget that everyone should be trained. It is desired thing from IDA also. But it is a strategy, not a solution.
I think both the faculties are winners today. But and we will have to listen from our moderators, Dr. Vijay and Dr. Jason, about their views on this particular topic. Vijay, ma'am, please. Yes.
Yeah, okay.
Yeah.
First of all, congratulations to both of the speakers. They made their point very well. However, I'd like to bring some few points over here. First of all, in pro-con debate, only the first speaker gets to rebuttal, not the second speaker. So the second speaker should just... The second thing is, I think the topic here was in the difficult airway, not in the normal airway. So what Rishali most of the times kept on saying was in the normal airway. So there is no doubt that one should need to have the skills of using our Macintosh laryngoscope blade as of now today. But if we are going to sort to the video laryngoscope in the difficult airway situation, I don't think there is any harm if tomorrow we decide that we are going to the direct laryngoscopy skills are outdated. Because if you look at the evolution of direct laryngoscopy, initially we always said that it has to be sniffing air position and there has to be pillow. Now actually they are coming out and saying in difficult airway cases, you can remove that pillow or head ring and give the extra neck extension. So to my knowledge, even that so-called principles of direct laryngoscopy have been changing. So it's like that. If we say that my Aji was cooking on the chula, does that mean today I need to know the skills required to cook on chula? No, because we know the hazards of it. So we have to move ahead with the technology, which makes us safe. So if tomorrow, now the only limiting cost factor over in the video laryngoscopy is a cost. I mean, there is no doubt about it that video laryngoscopy gives you an excellent view. You are intubating under vision. Like I remember so many times of even today, my juniors, when they are doing the first laryngoscopy using Macintosh blade, many times they tend to put the tube in and the tube gets fussed out in the arytenoid, interarytenoid junction or on the vocal cord. I mean, if you've got video laryngoscopy, the chances of that are much less. So when we are talking about the safety, I feel video laryngoscope is, I understand Rishali also agrees with me. Only thing is that she had to do that bad job because she was in the debate. So I think today, as of now, we say that yes, my students should learn the physics and physiology of how to do the direct laryngoscopy using Macintosh blade. However, I think in future, now we have got these BPL laryngoscopes, which cost 75,000 rupees. Good visual. And those disposable blades cost you some 250 or 300 bucks. So it's quite affordable. And today when we're talking about people are moving to robotic surgeries, even in the peripheries, I don't think we should be hesitant in saying that this is something which is required and we should get it into the picture. So it's not I'm supporting Gauri because she's from my institute, but I feel that the time has come that we have to move ahead with the technology and video laryngoscopy. No doubt that in the difficult airway situation, it's important. But let me make one point for the Rishali is she's absolutely right that when you talk about difficult airway, it is not only difficult intubation. It is difficult mask ventilation. It is and Vishali spoke about the definition of difficult airway from the 2014 guidelines. The 2022 guidelines says difficult airways, difficult mask ventilation, intubation, difficult laryngoscopy, difficult extubation. So when you talk about all these areas of difficult intubation, the video laryngoscopy is only playing a part in one part. There's difficult laryngoscopy and intubation, but for the difficult extubation or for the difficult mask ventilation or the patients who have got trismus, the VL scope has definitely got no role. So let's say that it has got a role in difficulty where the video laryngoscopy is important, but you need to have the, so in the our size of the difficult airway cart, I don't think it's going to reduce the way Gauri said. I still need all my airways, nasal and oral. I still need FOB. I still need my bougie. I still need my airway exchange catheter when we're talking about difficult extubation and the other things. However, I feel still that video laryngoscopy is here to stay. It's here to evolve. And whether we like it or no, the direct laryngoscopy using Macintosh blade is going to go out, become outdated in another 5 or 10 years. That's what is my feeling. Now, if Jason wants to add anything.
Thank you, madam. And Gauri and Roshali, madam, both excellent presentations. So, and very well summarized, Vijaya, madam. Just a couple of things that I feel were necessary, that here we are looking at training in 2 different gadgets. No one-stop solution for managing the difficult airway. Every patient is not the same. Every patient is going to be difficult. Sometimes you have a Cormac-Leon 3, Cormac-Leon 4. So if you use an angulated blade of a video laryngoscope, that makes it to 1 or 2. So the apprehension here is to use a new equipment. I understand that whenever supraglottic devices were first came into play, there was a lot of apprehension that people are inserting these funny things inside people's mouths, and the ethics committee will never give approval, and you are losing your laryngoscopy skills, and some paramedic will go and manage the airway and you will lose your skills. So video laryngoscopes are relatively new as compared to direct laryngoscope. So some amount of apprehension with a lot of people is going to be there. The solution to that is you have to train in all these equipment. You have to come over the learning curve, maybe not master the entire 20 or 30 battalion of video laryngoscopes. You choose your pick. You choose what suits your institute. You choose what suits your budget. Fine. You master that technique. You master the learning curve. You become proficient in the use so that you're not stuck in an emergency situation. And you see what suits your budget, what suits your cost. So again, every patient is going to be a different patient. There is no one-stop solution. If you fail with a direct laryngoscope, you move to a video laryngoscope. If you fail with the video laryngoscope, you move to a direct laryngoscope. And here again, there are 2 important points. When you are training students, especially if you're in a training or a teaching institute, you have to have more than one plan ready to manage the airway. If you fail with one thing, you have to have another alternative plan B, whether it is video laryngoscope, whether it is fiber optic, whether it is supraglottic device. That is why you need to train in all of these different scenarios. So the solution here is come over the learning curve, come over the fright, use an equipment which suits your needs, and be proficient in its use on a regular basis rather than getting stuck in an emergency situation. Again, it's very helpful in teaching, and that's about it, I guess. So I think most of the other points are already covered and well summarized. So I think it's not to give up your skills of direct laryngoscopy. You have to train residents, you have to train newer generation in both, so that suppose you are using a video laryngoscope and the screen goes off or the battery goes off, or the bulb goes off, some LED screen comes off. So then you should not be stuck waiting for another scope to arrive and mask ventilating or doing something like that. Obviously, you should mask ventilate, but at the same time, if you have a direct laryngoscopy at bay, you should be able to use that and intubate the patient. So they are not here as a replacement. They are here as an additional tool to help you out in a difficult airway scenario. That's my take on that.
Yeah, but I think the answer to the debate, whether it's a strategy or solution, I agree with Vrishali. It is a strategy.
Yeah, correct.
Solution for all difficult airways. It's a strategy.
It is not here to replace. It is one of an additional armamentarium. Yes, agree.
Thank you, sir.
Thank you so much, our moderators for today's session, Dr. Vijaya, Dr. Jason, and the excellent speakers, Dr. Vishali and Dr. Gauri. It was an excellent debate. Yes, we know it is anesthesia. We are debating for the topic of anesthesiology, scientific knowledge, but since it is a debate, we have to consider. I know that Gauri was also aware what Vrishali was saying was absolutely correct, and Vrishali was in the soup today. She had to speak totally against what she is practicing. So, yes, but it was a debate, and it was really an excellent debate. And thank you very much for that excellent debate. So let's move on the second topic, another important, interesting topic. I request Dr. Anita Madam to introduce both the speakers.
Yes, thank you, Manisha Madam. And so let us move on to the second topic, very interesting topic of today. Is the bougie redundant in difficult intubation? That is Malampatti grade 3 and 4. And we have Dr. Sonali Saraf, a young and dynamic anesthesiologist from ISA Thane. And she has got multiple publications on various subjects in the national and international journals. And she has a special interest in anesthesia for solid organ transplant. Welcome, Dr. Sonali. Opposite her is Dr. Sachin Chandolkar, and I welcome Dr. Sachin, and he is MBBS, MD, and LLB and LLM. Varsha, please display Dr. Sachin's CV. So Dr. Sachin is LLB and LLM, and he has got degrees in criminology and diploma in taxation law, and he is an advisor to legal as a legal consultant to 2 private medical legal services, and he's an advisor to even Indian Society of Anesthesia, ISA National, and IMA also, IMA legal body also. So we are very happy to listen to both you speakers, Dr. Sonali and Dr. Sachin. And I request Dr. Sonali to please start her presentation by sharing her screen.
Thank you, Madam. Dr. Nehate, Dr. Katikar, Dr. Saleh, and all the office bearers. Let me start by sharing my screen. Can you all see?
Yes.
Yeah.
So, a difficult task given to me today by Madam, Katikar Madam. Hope I am not performing any sacrilege by going again, speaking for the redundancy of bougie in a difficult airway scenario. So, in Malampatti grade 3 and 4, where we are anticipating already that the intubation is going to be difficult, then what is our stand? Is bougie redundant? I'm speaking or I'm saying that the bougie is redundant in cases of difficult intubation. So let's see quickly. A bougie is nothing but a thin plastic rod or a rubber rod which is passed into the trachea using a direct laryngoscopy, over which an endotracheal tube is inserted. The problem is not when we can visualize the larynx completely. The difficulties arise in control of our airway when there is something impeding our view. And that can be because of numerous secretions, hematomas, or edema of the larynx, or the surrounding structures, radiated neck, trauma, any anatomical variations of the airways, airway masses, presence of obstacles like cervical collars, and deformities of head, neck, orofacial injuries, or any blood and secretions in the way. So we all know that the bougie was introduced by Macintosh in the year 1949. And they also, unlike nothing is same, there has to be a progress. So we started from a normal rubber or a plastic tube to a Eschmann tracheal tube, which is shown in the picture next to this. The gum elastic is a misnomer. Usually they don't have any resin in them, but this did have an outer resin layer. From there, we progressed to having many intubating, them being called as introducers to the endotracheal tube. We have the Froas intubating in this thing, bougie, the Sunmed bougie, the Greenfield Flex Guide endotracheal tube, various names given, the entry intubation catheter or an airway exchange catheter. But we can see here, These are the different types of bougies that are available with the angle of the tip, which is the coude in French language, and it is at an angle of varying angles from 35 to 40 degrees to the vertical. Then we can see that gradually we progressed from a solid bougie to a hollow bougie with an eye, or so that we could ventilate the patient. We could attach a capnography. We could attach the devices like the esophageal placement device, and we could see. We could. It also came in numerous serrations, so it could tell us at what mark we are, so as to thread the tube. So various different methods of introducing bougie are described, the commonest of which is a hold-up sign. The hold-up sign is nothing but passing the bougie on after doing a direct laryngoscopy and passing it up to 40 centimeters. Beyond 40 centimeters in an adult, there will be some obstacle, or it will be caught in some of the narrow airways. So this is the hold-up. Without exerting too much pressure, we do know that it is in the trachea. If the bougie passes for more than the designated centimeters very smoothly, then that only means that it could be in an esophagus. So we have to check the position. Nothing will tell us about the definitive thing, but a capnographic confirmation. Something like a light wand also came into our practice, where initially it came as a lighted wand over which an endotracheal tube is threaded, and we could pass it without even giving the wide opening with a laryngoscope. We could just see the light at the end, or the light at the larynx, and we could guide the tube over that. That progressed and came with an eyepiece or a camera, so as to show us the structures through which it is passing. So just to revisit, Mallampati grade 3 and 4 does not necessarily translate into us having difficult intubation at all times. So since there are multiple tests involved, we know that this is going to be a anticipated difficult airway. We would take all the precautions and all the preparations as was discussed previously. But we will see on direct laryngoscopy, if this is a vision, to my left-hand side is the most easiest of the views, which is just a Cook's modification of the CL classification. So on direct laryngoscopy, if we see grade 1, grade 2A, doable. Grade 2B with exterior laryngeal manipulation, doable. What happens beyond grade 3A, 3B, and grade 4? This is the time when you would go for your other airway gadgets. So what does our IDA guidelines say? So a pre-shaped stillet or a gum elastic bougie being used to facilitate tracheal intubation in a Cook's modification of the Comac-Lehane grade 2B and 3A of the laryngeal view. However, a blind insertion in a grade 3B or grade 4 direct laryngoscopic view is not recommended, as it can easily lead to airway trauma. Where does our bougie stand in the difficult airway guidelines? So in cases of difficult airway guidelines, we can see the first step to begin with is a laryngoscopy, and for the laryngoscopy and tracheal intubation is attempting with a direct laryngoscope or a video laryngoscope. If that is not successful, then we go and have other things like our stillet or a bougie at hand. So it is very important to see how the things changed over a period of time. We don't wait for the oxygen levels to fall. There should be absolutely no failure of oxygenation at any point in the to oxygenate the patient. So we need to step up and put video laryngoscope higher up in the armamentarium. So what led to this question? There is a correspondence in the British Journal of Anesthesia in the year 2017. And this was a case, interestingly, a 51-year-old woman presented for a rectal tumor excision. And she had Malampatti score 3. So she had a small mouth opening. Video laryngoscope was kept ready as a planned, and intubation was done with a direct laryngoscope. And with an expert anesthesiologist, he could intubate easily using a bougie in the first attempt without causing any trauma. So this led to a question or a discussion amongst the peer group as to whether this technique should be introduced to the trainees, where Komaklihan grade 3 view to the intubation should be attempted with the help of a bougie, or we should be going directly to the video laryngoscope, keeping in mind that video laryngoscope is not available with everybody. So let us come to the complications of using a bougie. So first and foremost, a blind or the force that can be exerted causing trauma to the airway and the soft tissues. The incidence is greater with the bougies having a stillet, metallic stillet inside. So removing a stillet at some point may be useful in certain scenarios. Single-use guides are more traumatic than the multi-use guides, because multi-use guides soften over a period of time and get blunted. So single-use may be more traumatic. Creation of a false passage is a possibility, especially if we are going blind. Bleeding and hemorrhage if we cause inadvertent airway trauma. External airway compression if it goes into a false passage. Heaven forbid we pass a tube over it, start ventilating, then there is an external compression over the trachea, and these complications are known to happen. Suddenly a false passage creating a tension pneumothorax or leading to a life-threatening emergency, causing bronchospasm. Bougie fracture. The usual site is where the metallic stillet ends and the bougie curves. So this is commonly seen if we are trying to reuse the Provas catheter. Transmission of disease if they are not cleaned and sterilized properly, if we are using the reusable ones. So, and other complications, all other complications of endotracheal intubation, including the direct laryngoscopy, are all there, are all cited as the complications of a bougie. So there was never a trial which compared, even in a normal patient, how whether the use of a bougie facilitates a first attempt intubation, or whether just a tube, endotracheal tube with a stillet, we will be able to intubate the patient just as easily. And this is the bougie trial, which was published in JAMA in 2021, a multicentric trial, which has gone which has taken cases from over 8 intensive care units and emergency departments, and they have devised a strategy. They have studied over 1,000 patients, and each divided randomly into 2 groups, where critically ill patients undergoing tracheal intubation who have arrived at an emergency or are there in the critical care would, after doing a direct laryngoscopy, whether bougie would facilitate a quicker intubation and the success after the first intubation, or whether just using an endotracheal tube with a stillet. And they found no statistical difference. The success rate was around 82% in the group with bougie, 83% in the first attempt, using an endotracheal tube with a stillet. So we want to show again a rule which is published amongst the difficult airway discussions that have been happening in the British Journal of Anesthesia in 2016, where it says that bougie may not be a solution when we are already faced with a difficulty in viewing the larynx or in cases of a difficult airway. So indeed, in these in these situations, it would be the video laryngoscope which would be more useful. Not only because with a laryngoscope and a bougie, you struggle alone. When we use a video laryngoscope, we struggle as a team. We know what is happening. Others can see the screen and give the the amount of pressure or external laryngeal manipulations that can be done to get the picture in view. Also, we tend to exert less pressure on our maxillary incisors and on the base of the tongue when we are using a video laryngoscope. Plus, the curves, additional curves of the video laryngoscope help us visualize the larynx better. And another, but not the least, we have channeled video laryngoscopes available now. So maybe in these cases, bougie would really become a redundant thing. I thank you very much for your patient hearing.
Thanks a lot, Sonali. It was really an excellent presentation. Let's listen to now Sachin, what he wants to say on this. Sachin would like to share his view, whether bougie is redundant in difficult airway or not. So Sachin, you will mention that, you have to say that it is not redundant. So let's listen from you. Yeah.
Thank you, madam. Yes. Good evening, all participants and viewers and moderators. Thank you, Madam President, inviting me in this debate, and very much thankful. We from ISA Nanded conducting this academic activity. I'll start my presentation. Is it visible, madam?
Yes, yes.
Yes.
Yeah.
So Madam Sonali, it is no, I think, and I'm saying firmly, no, boogie is not redundant. It is a stick in darkness, only severe in difficult airways for remote places. Myself, Dr. Sachin, I'm Secretary, ISA Nanded, and freelancer since 2008. Price of bougie, video laryngoscope, and fiber optic bronchoscope you see on screen. The bougies are easily available up to 200, and VLS is really costly. And Vaishali madam explain on that also. And fiber optic bronchoscope is very, very much costly. So according to price, I say it is negligible. As per places like remote places, ER, emergency rooms, CT, MRI areas, where you can easily anticipate the difficult intubation, and it is the wisely choice. Even ICU setups, you can exchange tubes in difficult intubated patients. So it will be very much handy. Even risk, no trauma, it is malleable, gum elastic boogie, so no, nothing to worry about related to trauma to the airways and larynx. As it is a gum elastic boogie. Advantages, it is a reusable, malleable, cheap, can be carried easily, as by private practitioners, can be easily carried. And fiber optic, it is very much heavy box, you have to keep with you. And even no risk of stolen that boogies, that your boogies is stolen. If fiber optic stolen from you, it's very difficult to recover that cost. But boogie is 200 rupees, so you can buy a new boogie also. So even one article that shows first pass success rate is increased with boogies. Nasal intubations, pediatrics, and infant boogies is very much useful. When it is used in nasal intubation reported by Arisaka and team use this technique. 16 cases where conventional nasal intubation had failed because of anatomical problems or maldirection of tip of endotracheal tube. So there they use this, and they mention that it should be used first line of our arsenal. Even in pediatrics patients, Komasawa and team reported a research article in which They used Cortex boogies in infant mannequins and mentioned use of gum elastic boogies shortened the intubation time and improved first pass success rate in difficult infant tracheal intubations. So even with the scopies and using steroids, you need a lot of force, so causing more trauma. With boogie, less force, less trauma, easy to do. So other problems with spasms, heart rate increase, hypertension, others, these will be substituted. So there are so many VLS and with boogie. So Cook modified the Cormac-Lyon grading. So it will be grade 1 and grade 2A. It will be easy, and grade 2B and grade 3A is challenging task. That will be easily happen with boogies. And grade 3B and grade 4, it's difficult task with boogie. I also accepted. So difficulty in ETA is reason for that. It is body fluids obstructing the laryngeal view, airway obstruction, edema, obesity, short neck, small mandible, large tongue, facial trauma, or cervical spine immobilizers. In this, this happen in ER only or in ICU setups only. So effect of use of boogie with ET stimulate, it's better to first pass success rate is more in difficult ETIs. So back to boogie. Boogie is very much easy up to 3A. So everybody knows that. But what about 3B and 4? And our case is also about related to Malampatti class 3 and 4. So I am up to 3A is good. We can use 3 boogie easily and it's cheap. But what about 3B and 3-4? So its FPS rate is also going down after 3B. We will see how to use holding, introducing a boogie. Use naked boogie with the scope. I have here mentioned about VLS. So my part is boogies are needed in difficult intubation with VLS. It will be best practice in future. So one of the best thing is click and hold up sign gives you confidence that we are in. And here even VLS can happen that batteries can go down and there you cannot able to visualize the screen. Still you are in the confident that click and hold up sign give you confidence that we are in the right place. So assessment of tracheal tube introducer as an endotracheal tube placement confirmed device, and it was literature presented and it mentioned in 2004 that click is very much sign that you are in the right place. Even VLS related problems are there. Video laryngoscope differs sensitivity in illumination in the oral cavity. And there are a lot of studies on that also, that photographers and operation theaters diaphragm illumination may cause that illumination in the oral cavity by VLS decreases. So you need one hand like boogie for 3B and 4B. So it's the effect of use of boogies that you can, FPS rate is 97% in grade 2, even 96 is grade 3. And so it is better to use always boogies. Classic boogies easily usable in grade 3A. So with MacVL and boogie, you can easily surpass that 3B and 4. Like compression needed 2 hands. So likewise, VLS needed boogie for 3B and 4. Gum elastic boogie, you can use as an exchanger also in ICU setups, even in other setups also. So application of gum elastic boogie to nasal intubation, I also mentioned about that. Here are the pictures. Easily gum elastic boogie is entered in vocal cord area, so easily able to tip of endotracheal to pass the tube. Thank you, ma'am.
Thank you very much, Dr. Sachin. Yes, we are very much confused now whether to use bougie for a difficult airway or not. Sonali, what you want to counter?
A nice presentation, Dr. Sachin. The thing about already having a difficult airway scenario or anticipating a difficult intubation, in these scenarios, maybe bougie comes as a thing which will be in our armamentarium lower down. If the choice comes between using a video laryngoscope and using a bougie with a direct laryngoscope, then obviously the choice would go towards video laryngoscope, because the visualization of the CL grade would definitely improve with the help of a VL scope. So I would suggest that invest today for a better tomorrow. Like we invest in our in some schemes or your mutual funds. So invest a little bit, keep a money aside, and invest a bit for having a better video laryngoscope and not facing this scenario where we couldn't intubate or we have caused additional airway trauma. As you know, medico-legally, these would have huge implications, because failure to oxygenation due to iatrogenic trauma would be a disaster. Secondly, the study that was quoted was the BEAM study, BEAM trial, where the first pass intubation was tried in the patients coming to A&E, and you'd be surprised that the bougie trial is conducted by the same group of people, that being a multicentric trial and more recent than the BEAM trial. So yes, my argument stands that gradually bougie may become redundant, especially if we have better channeled scopes. And the same thing which a bougie would do with a VL scope can be achieved by angulating the stillet put in the endotracheal tube. So bougie would be redundant soon in the difficult airway scenarios.
Yes, Sachin sir, what do you have to say on this?
Madam, which VLS I should use when I say that I should not use boogies in future? Lot of VLS are there. So, and how many cost? It will be really worrisome. VLS needed more expertise. Very much learning curve is there. In FMB also, in my institute also, there are only APs or lecturer HODs they used to use FOBs. And VLS is not easy to procure at private forums or any practitioner who can afford that 45 Ks. It needs training, a lot learning curve, a lot of aseptic precautions. You have to maintain that FOBs and VLS to cleanliness. All these things can be needed. But this is the very cheapest boogies. You have to keep in future also and present also, in past also. So boogies are never redundant. It is a mandatory list. That mentioned by Vaishali madam also. It is in mandatory list. You have to keep in it, and not at all any article that they mention that is no needed boogies. And even Sonali madam also mentioned AIDA that 3B possible with boogies and 3B and 4 needed boogies with VLS or any, not blind direct laryngoscopies. Even T-Greg slide mentioned by madam, that even there, that last slides also, first presentation by T-Greg, he did intubation by an expert person with boogie. So no need to worry about that. In future, you have to forget about boogies. You have to use it, and you have to, because any failure in your FOBs and VLS needed electricity also, a lot of batteries, manpower, all these things needed. And anytime electricity failure can happen, batteries can go down. So you needed always boogies. Thank you, madam.
Thank you so much, Dr. Sachin. I think in a difficult airway scenario, whenever we face difficulty in intubation with direct laryngoscopy, the first thing we utter from the mouth is, "Arey bougie kya, bougie lo." So I think with that point in mind, let us listen to Dr. Vijaya ma'am and then to Dr. Jason about their views on this topic.
Yeah, very well presented by both the speakers. And again, to certain extent, I would just like to tell one this thing to audience. When we talk about pros and cons, no, the pendulum always swings in two extremes. It never comes in the middle, and it's the job of moderator to get that pendulum in the middle. It's not that the speakers do it because they are convinced, but it's because their job to show you the extremes of both the things. But here I would just say that I don't think Buji is here to go, because there are two things. One is, even if you do the video laryngoscopy, if you get a good view, that is one thing against the video laryngoscope, that you have got angulated blade, D-blade, you get an excellent view, but that does not guarantee that your tube will pass. And you always need that stillet inside, which will give you the hyperangulation. Now, again, most of you must be aware that when I'm doing the laryngoscopy, it's like I have my neck extended. My trachea is of this shape. And then when I put the tube in, it tends to go and hit against the anterior wall of the trachea. And many times you cannot push it forwards. The only answer for that is to drop your extension. So the trachea comes down and the trachea's angulation becomes little less. And that's where I feel many times the Buji is useful, because you can just pass the Buji. It's a small structure which can easily go. You can drop down your trachea by decreasing the your force on the laryngoscopy, where your vision may be going. You will not see the vision, but you know that your guide is in, and on that, then your tube walks in quite easily. So I think if you take, every device has been associated with complications. I mean, anywhere you go, you'll always have, there's no device which is with zero complication, nothing in the world. So anywhere you go, you are going to have the complications, and that's where our restraint comes into the picture, knowing where to stand and where what to use. So I think in Buji, what the previous Sonali said, I completely agree that, in the hands in very bad people, if they just shove it in, it has got lots of risk of causing the trauma. But if you use it carefully, I think it's still a good device. Like last 2 weeks back, me and Jason intubated a very, very difficult intubation child who was operated before on the airway. She was just 4 years old. And there, with the video laryngoscopy and Buji, we could easily get the airway. So I think the Buji has got a place and it's here to stay. And another thing with the Buji I find is, if you've got a ventilating Buji, so it depends on what Buji you select. So you have to select your Buji well. So we've got lots of companies in the market, and I've seen really bad Bujis, like literally a trash, very hard Bujis, traumatic Bujis. So if you select your good Buji, you have got a ventilating Buji, it also helps you to give oxygen and during the procedure. So at least in my opinion, Buji is not that bad. It's quite good if you use it properly. And as what Sachin said, that yes, when the peripheries, if you do not have lots of gadgets, you cannot use them. Buji is still quite handy for that matter. So what's Jason's view? Jason can talk about it.
Very well summarized, madam. Thank you, Sonali and Dr. Sachin, for really defending your topic very well. But if you ask for me and my opinion, I would go with what Vijaya madam said, because we often do that. We use a angulated video laryngoscope blade and we use a Buji very often. Now, my take on this is that, one, you should never insert the Buji blindly. If it is 3B or 4, you try and optimize your laryngoscopic view to make it 1-2. Either you change the operator, you change the device, you change the position, you change the video laryngoscope, or you move on to a video laryngoscope and improve your glottic score, CL score or POGO score or whatever you are doing, to make maybe 3B or 4 to maybe 2 or 3A, right? So never insert a Buji blindly, because again, if there is a stillet there, you are likely to cause trauma to the airway, likely to perforate some structure there, likely to cause edema, bleeding. It's not that bleeding with an Buji guided intubation is without risks, and we've had bleeding into the airway also. So again, take home message here is, if you have 3B and 4, don't shove a Buji in, be gentle in using it. Okay, and try and move on to a video laryngoscope and a Buji guided insertion. The way a Buji helps is like what madam said. If you have an angulated blade, very often you will be able to see the glottis fantastic, but your tube will always enter posteriorly into the esophagus or hit the arytenoids. So in that case, if you have a Buji, which is a smaller structure, a narrower structure than an endotracheal tube, it has an angulated tip. So it is directed anteriorly. Okay, and sometimes you have Bujis which are soft tip Bujis also. Okay, so this, a little rigidity, a little smaller bore, and this angulation helps in directing your bougie anteriorly under vision, and over that you can railroad an endotracheal tube. Again, blind insertion, if you are attempting it, I don't think that is the take-home message here. If you still have a grade 3B or 4 view with a video laryngoscope, I think you need to change your airway management strategy and move on to a supraglottic device or rescue face mask ventilation rather than repeated attempts and causing traumatic intubation and making the airway worse. Okay, so here that is what I feel. And okay, if you ask me for a verdict, I think I am always going to be using bougies unless there is something superior that comes up, whether it is with a direct laryngoscope, whether it is with a video laryngoscope. And I use it on a regular basis. Like Vijaya madam said, we just did a complicated child, and that's not one of case. Multiple cases like that with angulated blades, with depending on what is the mouth opening, what is the airway difficulty, using a stilet, using a bougie, depending on what the situation demands. Yeah, so that's my take on that. Thank you.
Yes, thank you, sir. I want to share my experience. Recently happened when I was there in the Kashmir in Kupwara. There was a mega camp, surgical camp was there, and one patient was posted for cholecystectomy, and the anesthesiologist there, he induced the patient and attempted intubation, but he could not. So he called for help, and I go there, and I just also tried one attempt with routine laryngoscope, and we could not see the cords, and it was a 3B position at that time. So I just put the LMA there and ventilated the patient, and I brought the Trupti blade, and with Trupti blade and with changing the position, removing the pillow, all we do, but the cords we could not see. Then I took the bougie and just passed below the epiglottis, and the click is there, and I railroad the endotracheal tube, and intubation was successful at that time. So there was no video laryngoscope or all other gadgets were not there, and we just intubated because of that small bougie only. This was my recent experience in 4 days back.
Yeah, thank you, Avinash. Thank you so much for sharing your experience. There are a few questions in the chat box. Can we take them?
Yes. Let us take questions. Yeah. One question is, can we use bougie for blind nasal intubation? So, yes, Dr. Sachin or
blind nasal? Yeah. Vijaya ma'am. Vijaya, Jason, anyone?
Yeah, so if you ask me for blind nasal intubation, I am not a very strong proponent of blind nasal anyways. In today's era, I am not a very big fan of blind nasal, because if you have things which you can see, why would you want to do a blind technique? There are masters of it and they are very well proponents, but ignorance is bliss. I don't know what trauma I have caused, what damage I have caused. So I say I'm very successful and my success rate is phenomenal. But that's not the case. When you have a fiber optic, maybe if you tell me I'm not able to afford a fiber optic in a private setup or something like that, but there are fiber optic scopes which are available at a much cheaper price now. It's not that glass fibers, and you have chip-on-tip cameras, you have disposable fiber optic scopes which are available in as less as 30 or 35,000 rupees. So for me, if you ask me, blind nasal is out. I will always go with a technique which is under vision, whether it is a video laryngoscope, whether it is a fiber optic. In today's era, it is difficult to justify doing a blind technique, however good your expertise is. And I don't think that's the way forward.
Yeah, and the other thing is,
yes, ma'am.
I just really wonder why he's asking, because doing the blind nasal, you always go by the breath sounds, which you're not going to hear through the bougie. The second thing is, again, my little worry about the bougie is that when you're going blind nasally and you do not have a good guide, it's very likely that you may go in pyriform fossa or you may go in vallecula, and little bit of pressure over there, it's all mucosal structure. So it's going to cause lots of damage. So I don't think a blind nasal, what Jason said, 100% I agree with it. But again, knowing our country, knowing limitations, if it comes to that extent and you're talking about, because there's a patient safety in that in blind nasal, your patient is breathing spontaneously. You're not taking away any of the things. So if you still feel that your back's up to the wall, and if you have got that skill, you may try it again, but with the basic principles that 1 or 2 attempts, not going beyond that, not forcing. But I don't think I'll ever use bougie for that. I'll go with the endotracheal tube, maybe of slightly smaller size, but I don't think bougie is a good option for doing the blind nasal.
Yes, it can really cause very serious false passages and problems.
Yes.
And as Vijaya madam said correctly, that we listen to the breath sounds. We listen to the breath sounds. We feel the breath sounds, in fact, while putting the tube blindly through the nasal cavity. So that may be hampered if we put a nasal
You can connect the ETCO2 trace actually. You can connect ETCO2 and circuit. If you connect, then you can know whether the tip of the tube is approaching the cords.
No, Anita, you don't get good ETCO2 because most of your air leaks out. Bougie is very small. So if you look at in the ventilating bougie,
no, not bougie, the endotracheal tube. Okay. So bougie is out actually. If you are putting endotracheal tube away, and then you can use the ventihedral CO2 as a guide if the tip of the tube is going towards the cords. But with bougie, it is not possible.
Jason, but I would like to tell you, Tata was the place where I learned blind nasal incubation, and Vijay would like to do that.
Even I have done plenty of them, but not anymore. Probably I would do a retrograde even today, but not a blind nasal.
Yes. There is another question in the chat box. Can you put some light on ventilation through hollow bougie? Your experience.
Yeah, so I have used Prova, which is a ventilating bougie. So in those cases, most of the times what I have done is after the bougie has gone in and if there's some problem, I have attached the oxygen to the ventilating port. It can just give the high flow oxygen, which is directly being delivered at the tracheal level, which will cause entrainment of air and the patient's oxygenation can be maintained. Twice I have used ventilating bougie with the jet. Eventually, remember that with the ventilating bougie, which doesn't have any cuff or anything, and when you talk about any fluid, whether that's air or liquid, going through the smaller, narrow channel is going to follow the path of least resistance. So here is so much of a leak that you cannot ventilate with bag and mask using the bougie. It has to be the jet ventilation. So if you have got manu jet, so I have done that twice. So you can use ventilation with the manu jet, or you can just attach the oxygen as a continuous oxygen. But otherwise, you can't ventilate through the bougie. It's not possible.
Just one question here. Why would somebody want to ventilate through a bougie? I'm just curious to know. In the sense, there are definitive indications, but why would somebody want to do that? So with today's era, where you have Thrive, where you have high frequency nasal cannulae for oxygen, where you have mask ventilation with PEEP and with propped up position with 100% oxygen, why would you want to consider ventilating through such a narrow lumen? And
I think probably.
I think again it's unavailability of that. No, these are the things which are coming from the remote location, because Thrive and all, again, they're not very available. So it can be done. Like I'm not saying it's not. Yeah. Ventilation, like you can use it for oxygen delivery. Let me tell you, that is the advantage of ventilating bougie. So you attach the connection that comes at the end, which fits on your circuit, and you keep a very high flow. You have to keep 10 to 15 liters of the flow with which you can do the apneic oxygenation for the bougie.
Yes, but I think the person wants to know about oxygenation. Rather, he is saying ventilation, but he wants to know how to oxygenate through the hollow.
That means he must want about that some people just press the emergency oxygenation button, and they say that it work like a venturi. Is that correct with that bougie?
Yeah, it can. It can. Ultimately, what's your venturi? You are just passing through the pressure and high flows, which at the end of it will drop the pressure and enter in the air. So it can.
All these techniques are from remote area only.
Yeah, that's right. I mean, everyone has to. I mean, I know there is no dearth of innovation based on what are the needs. And our colleagues who are working in the periphery resource poor areas, I know they are doing a great job and they have got innovation. But only thing is that it's for, you can use it for oxygenation, not for ventilation.
Ventilation.
Probably
yes.
That's what he meant to say.
One more question is, can you reuse a bougie because it is supposed to be single use? That is a question.
No, you get reusable bougies, right? The Frova is a reusable bougie. I mean, the rest of the things are single use. But again, I have seen in my place also that when you say it's a reusable bougie, you will find those bougies with complete Ashtanga Vakra. Like, people will just keep on using those. So again, we have to know for how long, how many reuses is permitted. So as long as the curvature and stiffness is maintained, you can reuse, but not till it becomes absolutely serpent-like.
Okay, I want, this is from me, which bougie is your preferred choice, madam? Because there are lots of bougies available. So what is your preferred bougie?
Frova. Because I have been brought up and I like Frova. I don't know, maybe other people may have got, because we tried in between. We tried Rush bougie. We tried also the Hansraj Nayyar bougie. We tried 3 or 4 different bougies, but not very happy with it. The way Frova worked, I'm not happy with any other bougies that I have used.
What is your experience with optical stellate, madam?
Optical stillets, I have used lighted vans way back 98, 99. But after that, because we have got good fiber optic bronchoscope and all, I don't have experience about using the optical stillets. We don't have those.
So in between, instead of the optical stellate, we had a few goes at the Bonfils, but our indications are very limited because most of our intubations are nasal intubations for reconstructive surgeries. We don't require oral tubes in place. So that's out, we don't have too much favoritism over Bonfils videomolar, retromolar intubation. That is one. And second, I think the Cook bougie for the pediatric use, like what Madam mentioned, was Frova for the adult use. For the pediatric use, we have the Cook bougie, which is a little expensive, but that is also a wonderful equipment that we have and we have been using. And we are reusing that as well. So we either ETO it and get it cleaned and we use those. So that's...
Yes, thank you, sir. My question is, it is better to put a intubating LMA rather than the bougie?
No, there is one question that can you put bougie through supraglottic airway and then railroad the ETT over the bougie? So, my normal...
that was another question.
Yeah,
that is another question. I don't have seen it, but okay.
So it's one of the strategy which is mentioned, but again, in those cases, I think you will have to have some mechanism in place to confirm that your bougie is in the trachea. So some people say that if you have got a well-placed LMA, where you can confirm, again, you have to be sure that you pass. And nowadays we have given up the classic LMAs. Now we are always past the second generation. So there you can pass your Riles tube through the gastric port, confirm that you have got well-placed LMA, and then you can pass bougie over it, take out the LMA and railroad it. But again, what's advisable is then you check, just put your fiber optic and see that it's a bougie is in place. That's the recommendation. But obviously you are doing this because you don't have fiber optic probably. So in those cases, it just becomes that but I would, in my opinion, I would just say that here you are again taking a chance. Your probability will be high. You can say that I have got 90% probability or 95% probability that my bougie is in trachea, but it is not 100% guarantee. So if I face this situation, I will first confirm that my LMA is well placed by using our conventional test. I will pass my bougie through the LMA without applying any force. It just has to walk in. And if it walks in, then I will remove. I'll try and railroad my tube over there and I'll see. But I don't think I'll ever come to that situation. But that way, if at all someone wants to do it, they can use it. I don't know if anyone else of Manisha or Jason or Anita madam has got any other say on this.
Yeah, so here when you put a supraglottic device in place, you are taking care of the patient's oxygenation and ventilation, right? So if the indication is such that you have to have an endotracheal tube in place, then I would like to confirm that my LMA is in proper alignment. If your LMA is slightly rotated, or if there is a little downfolding of the epiglottis, or if there is arytenoid coming into the aperture of the supraglottic device, and if you put a blind bougie, again, you can cause trauma and you can convert a controlled airway into an uncontrolled situation. So again, if you're using LMA Supreme, or if you're using a preformed curvature, and if you're using Frova, which is a little rigid, you will not be able to pass the bougie through these preformed curves. And if you see the LMA Supreme, that has an elliptical airway channel. So it does not allow passage of fiber optic. It does not allow passage of the bougie very easily. It will go, but it will be very snug and it will have to be really pushed down. So if you have a wider supraglottic airway device, airway channel, like a Aura Gain or some other second generation supraglottic device with a wider airway tube, it is easier to pass a bougie through that. But again, never blind, that is one. And if you have to intubate through a supraglottic device, if you see the literature, all of them use an entry. So an entry is a device which is railroaded onto a fiber optic scope. You will go under vision with the fiber optic scope, put the entry into the airway, remove the supraglottic device, and then pass a endotracheal tube over that. So that is a safer technique. Blind insertion of a bougie without confirmation with the alignment of the supraglottic device with the laryngeal inlet is a little bit, I would say it's a risk to be taken.
What about blockbuster LMA? Any experience of intubating through blockbuster LMA?
So again, blockbuster is another one of those Ambu Aura I or Ambu the iGel and the intubating LMA. A lot of them, or AirQ. All of them have wider airway channels for intubating through them, and they have some amount of better glottic alignment because they have a ramp or because they have some form where the glottic alignment is superior to the other devices. So blockbuster also they claim, and the advantage of using a blockbuster is that they have an airway tube which has something like a fast track tube. It has a silicon tip tube. So the hold up at the arytenoid or the tip of the endotracheal tube causing laryngeal trauma is less when you use an endotracheal tube which is specific for that supraglottic airway device. So that is why if you're using blockbuster, then you have to use their endotracheal tube and their pusher for passing an endotracheal tube through the blockbuster and not a Portex tube through the blockbuster. Again, if you're using a Portex tube, that is very high likelihood that you will cause some amount of laryngeal trauma or arytenoid holdup, and that may cause a little bit of trauma there.
Thank you so much. Any more questions?
There are no more questions. There are some comments.
Yeah. There are no more questions. Avinash, you wanted to ask something about intubating NMA?
No, the answer is already given by sir.
Okay.
Just I want to ask whether it is better to put a laryngeal airway rather than attempting the bougie and all difficult intubation. We can continue with LMA. Can we continue with LMA only? If there is we are anticipating any difficult intubation.
So if you already have a secure airway in place, sir, then I would definitely proceed with that secure airway unless the situation demands, like if you're telling me that it's an intestinal obstruction with a full stomach and then proceeding with a second generation supraglottic device with a drain channel. Now it's not contraindicated, but definitely it's a relative contraindication. If your patient has vomiting with a second generation supraglottic airway device, then you are going to be in trouble. Or if there is a cesarean section with a full stomach, again, supraglottic device, it's not a contraindication. You can carry on till the baby delivery is done. But again, it's a relative contraindication. There is a full stomach there. There is always in all likelihood a chance that the patient may have an aspiration event. So if you give me a choice between supraglottic and endotracheal tube in these kind of scenarios, I will obviously prefer an endotracheal tube. But again, if you're telling me that laryngoscopy was grade 3, 4, I would be really worried to pull out the supraglottic device and then attempt an endotracheal tube.
Very true.
Okay, thank you, sir. Very true.
Yeah, it was an excellent discussion, excellent presentation, and excellent moderation by both the moderators. And there are many comments also in the chat box on my personal WhatsApp also that it was a really great discussion. We are very thankful, Vijaya and Jason, for your excellent moderation for today's interactive session on difficult airway. Avinash will do the remaining formality of both of them. It was almost 2 hours that we are onto this program, and many people are still logged in, and that is the most important part. Avinash sir, please.
Okay, it was an excellent interactive session today. Very good presentation by all four participants in this debate, and I congratulate them for their excellent presentation. I thank Dr. Gauri Ganga Khedkar Madam, Rishali Ankalwar, Dr. Sonali Saraf, Dr. Sachin Chandorkar, for their presentation. I also thank to Dr. Vijaya Patil Madam and Jason Doctor for chairing today's session and moderating and giving practical hints to all viewers. I also thank to Katikar Madam and Anita for conducting this session. Thank you very much. I think we'll meet in the next interactive session soon. Thank you. I just will come. Yes, thank you.
Thank you so
I
much,
declare this meeting is over.
Thanks a lot.
We can have a unofficial discussion. We will stop the recording and we can communicate.